Similar to the work I presented earlier on the off-pump stuff, this is an analysis from the SCTS database. This bit of work has been done primarily by a PhD student, Kate McAllister, who's working with us at University of Manchester with Graham Hickey and Stuart Grant's involvement. So we wanted to ask ourselves the question from the database, does using two rather than a single internal mammary artery graft have an effect on in-hospital mortality or survival for patients undergoing first-time isolated coronary artery surgery? So we've looked at all patients from April 2000 procedures up to the end of March 2011. We looked at England and Wales only because we have more robust mortality tracking because of the greater incidence NHS numbers for those patients. We excluded redos and patients having concomitant other procedures. And we looked at single mammary plus vein grafts versus bilateral mammaries plus or minus vein grafts in addition to that, and only looked at patients who had at least two grafts. So the kind of flow chart of the data, we started off with 186,000 odd isolated first-time coronaries, and then we excluded some patients because no graft data was available, some because the IMA wasn't used at all, some because other arterial grafts. So all the patients having double mammaries and radial grafts, or single mammary plus radial grafts, weren't included in this analysis. And that left us with 5,780 bilateral mammaries and 126,000 odd single mammary patients. We cleaned the data using the standard methodology which we described some of earlier, and for dealing with missing data, which is a relatively low incidence in the data set, we used 5 sets of multiple imputation for that. The propensity score matched on the basis of the BIMAs, 1 BIMA to 5 single mammary groups, and we looked at in-hospital mortality using logistic regression, survival analysis using Cox regression, and we did a series of sensitivity analyses on those. So the sensitivity analysis that we looked at was by patient age, by diabetic status. We looked to exclude low-volume coronary artery surgery patients, and then for the BIMA use, we had a series of thresholds looking at 2%, 5% and 10% thresholds for BIMA use. We also analysed it by BIMA proportion quartiles, and we put in 10% BIMA use as an interaction term into the model also. So the propensity score variables are listed there. I won't go through those with time, but they're kind of what you'd expect to have a look at. So pre-matching, the mean age for the single mammary group was 67, and for the bilateral mammary group was 60. The number of grafts average was 3.1 in each group, but the patients were significantly different prior to matching. Sorry, that table is wrong. So where it says CIMA, that's BIMA. The smaller group is the BIMA group, and the large group is the CIMA group. I apologise for that. But the CIMA group was sort of higher risk with respect to pretty much all the risk factors across the board. And after the matching process, and this is data from one of the multiple imputation data sets, there were still significant differences in diabetes, but that difference was much smaller than prior to matching and off-pump surgery. The off-pump surgery difference prior to matching was big, 12% in the CIMA group and 35% in the BIMA group, and that difference had decreased, but was still significantly different after matching that data set. So before adjustment, the mortality for the BIMAs is 1.1%, and for the CIMAs was 1.5%. But after matching, the mortality for the CIMAs was lower than it was for the BIMAs, and that was a clinically small but statistically significant effect. And then after adjustment, on the full cohort, the odds ratio for BIMA was 1.3. On the propensity match cohort, after adjustment, on the one imputed data set, it was 1.5. And if you look at the average across the 5 imputed data sets, the odds ratio for BIMA was 1.47, with a 95% confidence was 1.09 to 1.98. And when we looked at those various interactions that I described, there was no significant interaction identified for age, diabetic status, or surgeon volume. So basically what we're seeing is that bilateral mammaries have a statistically significantly but small increase in hospital mortality compared to single mammaries. So in terms of the survival analysis, before matching, the overall mortality, the number of patients who died in the follow-up period, which goes out to 10 years, was 13.7 in the CIMA group and 8.2 in the BIMA group. And after matching, it was still higher in the CIMA group, 10% versus 8.2%. So if we then look at a survival analysis, and what we've done here is we've conditioned this on discharge from hospital. So if you are discharged alive from hospital, that's the survival curve going out with time, where there is a benefit from bilateral mammaries with a hazard ratio of 0.85 again, which is a statistically significant finding. So again, if we look at that across the 5 imputed data sets, the hazard ratio is 0.86. And again, when we look at the sensitivity analysis for survival, there's no significant interaction for age, diabetic status, or surgeon volume. So our summary from this is that bilateral mammaries is associated with a statistically significant increase in hospital mortality, but that is clinically small. Conditional on survival to discharge, bilateral mammary is associated with a statistically significant survival advantage. There's no significant interaction between the things that we've described. We want to introduce into this an off-pump interaction term just to see if there's an interaction between those two things, and that's work which is outstanding for us to do at the moment. Thank you very much.